My name is Bill Kehoe. I'm a professor of pharmacy and psychology at the University of the Pacific, and I'm also chairman of the Department of Pharmacy Practice. My area is psychiatric pharmacy. I'm actually a clinical pharmacist also at St. Joseph's Medical Center, and my practice is at St. Joseph's Behavioral Health Center in Stockton, which is a 35-bed acute psychiatric hospital. But my real day job is a professor at UOP. So what I'd like to talk with you a little bit about today is pharmacy in a different kind of perspective than you might be used to seeing people who are dispensing and getting those prescriptions in your hands. Talk with you a little bit about the expanding role that pharmacy is probably going to have, at least I think, in the future. And if you look at the profession of pharmacy, there are some challenges out there that are going to end up causing changes to the way we do things and the way we think about things. And I think this is a good point in your career for you to be thinking about that, because I don't know how much exposure you've had to pharmacy. If you've shadowed some people, or you've been in a chain pharmacy versus independent pharmacy versus hospital pharmacy, I'm not quite sure. But the practice is definitely going to change. And if you look at some of those threats, healthcare reform is clearly one of those. I'll talk a lot about one aspect of healthcare reform, which is more of a team-based approach to how we're going to care for patients in the future, and pharmacists are clearly going to be a part of that team. But healthcare reform and how are we going to get paid for our services is a big deal, and it's a game changer for all of us in healthcare. Secondly, technology and manpower. A lot of prescriptions are still dispensed manually, where you have the bottle, stock bottle of medications, and you count them out and put them in a bottle and that sort of thing. That clearly is going to change, because there is equipment now that will do that and do it quickly without mistakes. And so the dispensing aspect around pharmacy is going to change. That will probably also affect manpower. How many people are we going to need to fill prescriptions? So for instance, if you look at some of the larger organizations, Kaiser being one of them, they have these places that fill thousands of prescriptions a day, and because they use technology, they may or may not employ as many pharmacists in that setting. So there are going to be some changes in terms of manpower, and we think, of course, that pharmacists are going to become much more clinically involved and part of teams, so they'll probably move out of that environment over into clinical areas. And then the other one I want to talk with you about is care models. And we're going to talk about team-based care. Where will the clinical pharmacist fit into that scheme? And that is something that's not a given. I need you to know that we're still forging out where we're going to be. We're still carving out niches. I've been doing this for a long time. I listened to the students a few minutes ago. I went to UCSF a long time ago, and for most of my career, I've been digging out a niche as a clinical pharmacist. And so if you think that you're going to enter a profession where everything is all set up and you're just going to fit right into a clinical position, that may or may not happen, because we're digging out where we're going to be as a part of the healthcare team, which is a very cool challenge, because then you get to sort of design what you end up doing. And so it's kind of an exciting time in pharmacy right now. So if you look at the different aspects of pharmacy practice in the future, clearly there are going to be issues around dispensing systems, what we call fulfillment, and getting the right medication to the right patient at the right time and the right dose, those sorts of things. Pharmacists need to manage those systems, but of course technology is going to become a really important part of that. And one of the career directions that you might think about in pharmacy that's relatively new is in informatics and information technology. We have pharmacists who are highly trained in that, and it's an expanding field. You can even get board certification in that area now, and they're the experts at developing things like clinical decision software, support software. For those of us who are taking care of patients, I've got my I've got my iPhone with all my stuff on it that I use, and that's just going to be an expanding field, and there are going to be a lot of Pharm.Ds that are involved in that. Administration and healthcare policy, clearly there's a role for pharmacists in that area, and I have friends who are experts in those areas. One of the administrative areas is pharmacoeconomics, which is basically the dollars and cents of healthcare. How do you optimize outcomes and yet minimize costs? And that's one of the things, as you hear about Obamacare and healthcare reform, whether you like Obamacare or you don't like Obamacare, the United States has to do something about its healthcare system because we're headed for bankruptcy if we don't do something about the cost of healthcare. And in the area of medications, that is a big part of healthcare. Billions of dollars spent on medications and billions of dollars spent on medication misadventures. And so we have people who work in those areas. I have two on my faculty who are both Pharm.D, PhD types of folks. And the one I want to spend the rest of the time talking about is clinical pharmacy and direct patient care. That's something that you may or may not have seen pharmacists do. Most of us, our exposure to pharmacists is when we've taken our prescriptions in and we've gotten them filled. Or if you've been in a hospital, you may have had a pharmacist come by your room and talk with you or something like that. But most people don't see what we do as clinical pharmacists. We're a little bit behind the scenes, and so to try and explain clinical pharmacy to somebody can be really difficult. I'm not sure that my mother ever understood what I do. My mother always, she used the word that I hate the most on the planet. She thought I was a druggist. Don't ever use that. I hate that word. But anyway, I'm not sure that she really ever understood what a clinical pharmacist really does. And yet, it's really an expanding field. All right, so some questions that we need to address, and as you think about your career and whether pharmacy is going to fit for you or not, what context are you going to practice in? There are a lot of different practice areas that you can get involved in. What are we going to do in that context? And in the context of clinical pharmacy, what is it that we bring to the party that other disciplines don't? Medicine, nursing, there's a lot of things that nurses do that gets very close to pharmacy. And who's going to do it? I'm going to talk a lot about who will do it because I heard one of the students, I think it was a young lady from UCSF, talking about how long you're going to go to school. Okay, you're going to do undergraduate, then you're going to do 4 years of pharmacy school, and then she mentioned residencies, postgraduate year 1, postgraduate year 2. Those are still choices that you make. You don't have to do a residency, but you'll, hopefully by the end of this talk, I'll convince you that you should think about doing that. It's going to be a very good idea. And then there are fellowships, and then some of us also went back to graduate school and have combination Pharm.Ds plus graduate degrees to do various other things. And so what does that mean in terms of what it's going to take to do some of these new clinical things that we're talking about? Well, let me take you back for just a little bit. There were the bad old days for pharmacy, and we're still paying for that. If you go back into the 1800s and you look at what pharmacists did, of course, they compounded almost everything they dispensed, but they also took care of patients. They didn't always just fill prescriptions. Patients could come in and they would give them medication and take care of their issues. At some point, there became a bifurcation of pharmacy and medicine. And somewhere along the way, pharmacy gave up a lot of turf. And along the way, pharmacy became basically a dispensing profession, and whether or not it was even a profession was questioned. A guy named Alexander Flexner, who's not on my all-time list of great people, described plumbing, social work, banking, and pharmacy as non-professional because they were unintellectual, highly profit-motivated, lacked a technique of their own, and lacked a primary responsibility. And he's not the only one that had that outlook about pharmacy. Whether or not it was even a profession was questioned for a long time. The American Pharmacists Association, back then it was called the American Pharmaceutical Association, actually said that a pharmacist should never discuss the therapeutic edict of a physician's prescription with the patron or disclose the details of the composition of that, which the physician has withheld, suggesting to the patient that such details can be properly discussed with the prescriber only. So that, when I was a kid growing up, meant that when you went to the pharmacy and you took a prescription, he would give you the medication, and if you asked a question, he would tell you have to go talk to your doctor. That's what that means. And that was in the APHA, that was in our own code of ethics till 1969. Sometimes pharmacy has been its own worst enemy. And those days are behind us now. And if you look at the movement towards a clinical role for the pharmacist, that has skyrocketed. So it began, in my view, some people from the East might argue with that, it began with the Ninth Floor Project at UC San Francisco. And they were very innovative. They moved pharmacists out of the pharmacy up onto the floors of the hospital. And the idea there was to participate more directly in patient care, to provide drug information on the spot when physicians needed it, and to do those kinds of things. And that began to grow and began to catch on. It spread across the country. Many schools began then not only offering a bachelor's degree in pharmacy, but they started offering the Doctor of Pharmacy degree. And in 1979, the American College of Clinical Pharmacy, which is one of the larger organizations, the American Society of Health Systems Pharmacists, they're the organizations that a lot of clinical pharmacists belong to. A CCP began in 1979 with 29 individuals, and now we have over 10,000 members in that organization. ASHP is even larger. ASHP represents a lot of the institutional pharmacists in hospitals and various institutional ambulatory care clinics, et cetera. And so it has clearly taken off. And there are a lot of pharmacists who practice clinical pharmacy. Clinical pharmacists, this is a definition, it's a sort of a view of what the clinical pharmacist does, and it involves taking responsibility, being accountable for medication management issues with your patient. And it's a direct patient care type of practice, whether independently or in consultation, collaborative agreements with other health professionals like physicians. And clinical pharmacists, researchers, folks like those of us in the academy, in universities, also are involved in a lot of research issues. We generate and disseminate medication-related knowledge. So the scope of practice for a clinical pharmacist is fairly broad, but it involves direct patient care, and it also involves taking responsibility and being accountable for that care. Go back 40, 50 years to the time when the pharmacist wouldn't even tell you about your medication at the counter. They would tell you to go see your physician, to today, where we're not only talking with our patients, but in many cases, we actually manage medication therapy for them under collaborative practice agreements. The Joint Commission of Pharmacy Practitioners, which is an organization that most of the other professional organizations have members appointed to, in its future vision statement says that pharmacists will be the healthcare professionals responsible for providing patient care that ensures optimal medication therapy outcomes. Now, this is an important thing to remember. We have a lot of medications in our country. We have a lot of people who prescribe medications, and we still have so many therapeutic misadventures that adverse drug effects and other safety issues related to medications cost our healthcare system a lot of money. And so clinical pharmacists are positioning themselves to be able to optimize medication therapy. And by optimize, I mean improve the benefit-risk ratios of using those medications. And that is sort of the point of our curricula now as we train pharmacists. We're training them, obviously, to do more than just be systems folks who put medications in people's hands. The Institute of Medicine, which is one of the most prestigious medical groups in the country, says that there's an urgent need for high-functioning teams. They talk about that there's frequently uncoordinated state of care who have not developed team skills, et cetera. And so the Institute of Medicine is saying we need a team-based approach. We need people to bring their skills to the table when we take care of patients. And all the disciplines have something to bring to that party. They also go on to talk about team-based healthcare being the provision of health services to individuals, families, and/or communities by at least 2 health providers who work collaboratively with patients and their caregivers to the extent preferred by each patient to accomplish shared goals within and across settings to achieve coordinated high-quality care. So clearly in our country, there's a mood now talking about team-based care. It involves shared goals. Obviously, we want our patients to have their health optimized, healed if we can, but certainly optimized. There need to be clear roles, and that is an area where clinical pharmacy is still developing. And it's not clear to some of the other disciplines what clinical pharmacy actually is and what we do. We've not been terribly good at that. It involves trust between the disciplines and communication, and also that we have measurable outcomes. So that essentially is what team-based healthcare is. Now, what is it that we're going to do as clinical pharmacists? There's not a lot of agreement in that area, and unlike, for instance, if you go to your physician and you go to the office, you kind of know what's going to happen, right? You go into the waiting room, you go up to the window, somebody takes your copay, then they call you in and you go into an exam room, they sit you on a table with some funny crackling white paper on it, and you sit there for a while, then a medical assistant comes in, and the medical assistant weighs you, takes your temperature, etc., puts the chart on the outside of the door. It's always the same, isn't it? It's always the same. And then eventually, you know, you wait there and you wait there and you wait there and reading Time magazine. Then finally the doctor comes in, and physicians will do an examination, and it's standard. My daughter's a medical student, and she does in Missouri, she does a physical exam just like a doctor here at UC Davis. I mean, they have a very standard approach. You know what's going to happen. Most of us don't know what's going to happen when a clinical pharmacist comes in to see us. It's a pretty well kept secret. And the other disciplines don't really know that. And so actually in pharmacy right now, we're talking about, well, what is it? What is the standard of care for a clinical pharmacist? And that's still kind of an evolving field of what it is that we're going to do. But essentially it involves medication management, assessing people's medication regimens, seeing if they have any problems, are we having good outcomes with them, how can we optimize them. That is the focus of what the clinical pharmacist is going to do. You can actually go online and find this. It's the Patient-Centered Primary Care Collaborative, which is a multidisciplinary group that has looked at team-based care, and in a reformed healthcare system, this is a model that you can look at. And the interesting thing is that they've described what a comprehensive medication management scheme should look like. And they talk in there about clinical pharmacists and what that role is. And we find ourselves working in a team that includes not only physicians and other providers for the patient, but we work with the patient. You always want to remember, patients are part of the team too. They have a lot of useful information, and besides that, I can put together the best medication plan on the planet for a patient, and if he or she doesn't want to do it, it's not going to be any good. So you have to include the patient as a part of that team. And so, you know, the pharmacist is going to be the person who is going to help manage medications and assure safe and effective use of those things. And with the number of medications that are coming out and are on the market, it's very difficult to know everything about all of those medications. And if that's not your discipline, it becomes even harder. And what we find is that other disciplines that are prescribers, often they have an armamentarium of medications that they're familiar with, and they're very good with them because they use them every day. But if it's something that's outside of that norm for them, it may not be quite as easy, and that's a role where clinical pharmacists can come in. So what is this that I'm talking about, this medication management process? It's really assessing the patient's medication-related needs. It's not only looking at drugs that they're taking, but it's also having the patient come in, and very often we find an untreated condition, and they may need something for that. We find maybe that they are on medications that they don't need. One of the roles I play is that for Valley Mountain Regional Center, which is one of the regions in California that takes care of the developmentally disabled, I'm their pharmacology consultant, And one of my roles is to look at patients who are on 15 or more medications to see if there are interactions, but also I find a lot of duplications because they go to 4 or 5 different physicians and not everybody's on the same page. And so I assess, I look for drug-related problems in that area, and you try to develop a care plan that has individualized goals for that patient to, again, try to optimize outcomes for them. The other kinds of things that we do, I'm not going to read through all of these, but we look at what kind of experiences patients have had with medications in the past. It's very, very important to understand, for instance, what their history of allergies are, but not just allergies. What kind of adverse drug reactions have they had with medications in the past? And then the idea is to set goals, to set the outcomes that you want to see, work with the patients to achieve them, assess along the way whether you are, and if you're not, then make the kinds of adjustments that you need to. And again, it's really focused on safety and efficacy. So one of the questions that we found, I'm involved with ACCP, and we've been working with other disciplines like medicine and such. And one of the things, or some of the questions that we get is, well, what are we going to get when we refer a patient to a clinical pharmacist? And that's kind of the thing that pharmacy has to address right now, is so that people understand what it is that we do for patients. And we're making inroads along those ways. In fact, the definition that the Patient-Centered Primary Care Collaborative has for medication management is a good step in that direction, because it really systematizes the kinds of things that we're going to do. Then they ask, how do I know that the pharmacist that I send my patient to is prepared to do what I need? Medicine is very used to sending people to specialists. We all go to primary care providers, right? And then when they want to send us to someone that's a urologist or an internal medicine guy or whatever it is, they send us to those experts. They always know why they're sending the person and who they're sending the person to. I mean, did you ever notice that? You go to your doctor, well, you know, I'd really like you to see an ENT person for that sinus thing that's going on. Let me send you to Dr. So-and-so. They know exactly what's going to happen when they send you there. And so they're asking us, well, what is it that we're sending them for? And then how do I know that this person can do what he or she says she can? Okay? How do you pick, if you're looking for a specialist, let's say you're looking for an ophthalmologist. How do you pick an ophthalmologist? Your doctor may recommend some, but how do you know if your ophthalmologist is good? Yeah, you research them online. I live in Stockton, and I had to have surgery last year, and I wanted somebody that I thought would be the best on the planet. And so I started looking, and I wanted the robot surgery, okay? Well, we didn't have a robot in Stockton yet, so I had to come up here. You got robots everywhere up here. So had a couple guys recommended, and then I just started looking on my own. I Googled them, and I found where they went to school. I found where they did their residencies. I found out were they board certified and how many different board certifications that they had. The guy asked me, how'd you get into my office? I tracked you down, dude. I know where you went to school. I know where you did residency. I know where you did your fellowship. I'm here because you know what you're doing. It's that simple. And I'm going to talk with you a little bit about pharmacists kind of moving into that space. How is it that people are going to know that we know what we're doing? But this is where there's also a lot of disagreement in the profession. I'm going to talk with you a lot about board certification in a minute, and specialty training. And the profession is not all in one place on this issue, all right? You have to realize that my understanding is that there's 200-something thousand licensed pharmacists in the country. That's a lot. The largest number of those pharmacists practice in dispensing out, going to get your prescriptions filled, whether it's at a chain pharmacy, independent pharmacy, or whatever. That's where the largest number of pharmacists are located. And because of that, you have hospital pharmacists, you have ambulatory care pharmacists, you have people like me. I'm a psychiatric specialist. So we all have our organizations that we belong to, and you'll find that pharmacy has a lot of different organizations, and of course each one has their own view of the role of board certification and specialty. You have to realize you only have to do two things in California to practice pharmacy. You got to graduate and get your Pharm.D, You got to take the board exam, you get a license, and then you practice, all right? But you're kind of an entry-level person at that point. And so there's not complete agreement on, well, what kind of postgraduate training should all pharmacists have? Depends on what they're going to do. What about board certification, which is not required? You only have to have a license to practice pharmacy. That is your entree into the profession. But what about board certifications? Do you want to be a board-certified pharmacotherapy specialist, an oncology specialist, an ID specialist? What is it that you want to be? And whether or not people need to have those or should be required to have those is not something that has been totally agreed upon. So what I'm trying to show with this slide is that the entry level is the Pharm.D, the Doctor of Pharmacy. Well, it went away, I guess. This slide. Then you have to ask yourself, okay, how much more do I want to do? Well, if you really want to do, only you can decide what you want your career to be, okay? If you're happy being in an outpatient setting where you're filling a lot of prescriptions, like one of the chain pharmacies where we go, that's great because there's a lot of good work to be done there. But you have to decide if that fits you. It didn't fit me. I'm a hospital type person. Some people are, I'm especially an inpatient person. That's just the environment I like to be in. I like the hospital. And I like a psychiatric hospital. I know what that quite says. I live in a psych hospital. Other people like ambulatory care. And so you have to try those on. You have to look at those and say, okay, what is it going to take to get me there to practice that? And that's where the postgraduate experiences come in. PGY1, PGY2, I'm just talking about postgraduate year one. First year residency, second year is, if you do a second year, is like a specialty. So you might do a general clinical residency, and then you might follow up with a fellowship or a PGY2 in infectious diseases or something like that. Pediatrics, oncology, whatever it is you want to do, transplant. There are then fellowships. Now, fellowships are more research-oriented experiences, and those folks are generally going to practice in fairly high-level clinical environments, and a lot of them end up in academic pharmacy, in academic medical centers, or teaching for people like me at the University of the Pacific. There's also a role for graduate degrees. I went back actually and got a graduate degree in psychology, more because of my interest in the psychiatric area. But as I said, I have people on my faculty who have both a Pharm.D and a PhD so that they can do the kind of research work that they want to do. Graduate degrees really do prepare you for research work, which if you're thinking a career in academic pharmacy might not be such a bad idea because of the whole promotion and tenure process that we all have to go through. And then there's the role of board certification that we'll talk about. Now, here's the problem. Because residencies have not been required in pharmacy. Now, by required, what I'm talking about there is, can you practice pharmacy without a residency? Certainly you can, all right? That's not to say that if you wanted a job at UCD Medical Center, they might not say that you have to have, they might very well say you have to have a residency to work for us in that setting. So the setting may decide that you need to do a residency. But in terms of practicing pharmacy, Pharm.D license is all it takes. So people have, a lot more people have started doing residencies. And the number of graduates has gone up every year because the number of schools. If you're not aware of it, California has a lot of new schools that are in various stages of being developed right now as we speak, not only in the Bay Area, but in Southern California. Fresno has a new school that's being developed. So there's a lot of schools being developed. So the number of graduates has just steadily climbed. And unfortunately, the number of residency slots has not grown at the same rate. So you have a lot of people who want to do residencies that have a hard time getting one. There's a match that you have to go into in order to get the residencies, and we find a lot of people going unmatched because there's not enough residency slots for the people who want residencies. So word to the wise right now, as you're at this point in your career, when you start pharmacy school, if you're thinking that you might want to do a residency, you come out of the blocks running hard, and you be as good as you can, and you get as broad of an experience as you can to position yourself to get one of these residencies, because they have become extremely competitive to get now. Now, in terms of board certification, a long time ago, the first one of these was in nuclear pharmacy. I think you can imagine why you want somebody who has board certification and is a specialist in nuclear stuff. I personally have never worked around nuclear stuff. I don't want to work around it. But there are people who like to do that. And that was the first board certification. And then after that, we had other things coming along. Nutrition. You can be a board certified nutrition specialist in pharmacy, and then pharmacotherapy. Pharmacotherapy is kind of a general term for knowing how to use drugs. It's sort of the pharmacy's version of internal medicine in a way. And now we have a number of other specialties. There's oncology, psychiatry. New ones are being developed in critical care and some other things. And if you're interested in that, you can go to the website of the Board of Pharmacy Specialties, BPS, and you can see what all's out there. And I just show you this slide to show you that board certification is really increasing in popularity, and more people are going for it. Let me walk you through a little bit about what you might think about with your, as you approach pharmacy school and your education, and where you might end up going. If you think about the kind of practice experience that you're going to be in, if you think about a very broad practice, that would be somebody like if you go to a CVS pharmacy, those folks see all comers. I mean, people come in with all kinds of issues, and not only for non-prescription medications, but prescription medications, so they see a very broad array of patients. And then you come over to someone like me. I see a fairly narrow array of patients. They're all with psychiatric conditions. Now they have other medical things that I have to worry about, but they're all in that hospital because they have a psychiatric condition. So I'm a very focused practitioner as opposed to someone who's a very broad type of practitioner. And then if you put this in a sort of a 3D context in terms of how closely are you going to work with patients. There are some pharmacists, obviously, in administrative roles, health policy roles, don't work with patients maybe at all. You come to someone like me, that's what I do every single morning, is I go in and I work with patients. And then, if you look at the outcomes of your pharmacy education, there are outcomes that are in your curriculum that are patient care related, public health, and systems management issues. You're going to get trained on all of those. But let's talk just about these that are the patient care related ones. When you come in to pharmacy with a Pharm.D, you're going to be up there in that left-hand quadrant. You're going to be very broad in your scope because that's how we've trained you. You haven't specialized when you come out of pharmacy school. And you're going to be sort of in an entry level. So that's where the Pharm.D is going to come in. The person who's got a Pharm.D, got a license, you're going to come in there. As you gain experience, you may decide that you want to either stay in sort of a broad arena, in which case you will become sort of an advanced practice type person, seeing a broad number of patients. A lot of my friends in AmCare and community pharmacy settings, they're seeing patients in a very broad sort of way. And they would be different than, say, somebody who's, let me move down there, more of an advanced focused practitioner with experience. And so I just show you this to say that you kind of start out very broad, and you can either be a more generalist type of practitioner, seeing all kinds of things, or you can become much more of a focused practitioner. And in pharmacy now, we have people that specialize in all kinds of things. I have friends that are transplant specialists. And the really cool thing about that is that if you have a medical center that does transplants and you're certified in doing that, that body requires that you have a clinical pharmacist on the team. And so our services are required there. And so we have people who've done residencies and fellowship training in that area. And so there are all kinds of specialties that you can become involved in. Now, back to the idea of credentials. Okay, so what makes me a psychiatric pharmacist? Well, I have about 25 years of doing that. I have a graduate degree in psychology. I am a board-certified pharmacotherapy specialist because that was the first specialty exam that came along. I took it the second year in 1992. The first one was in 1991. I took it in 92. There wasn't a psych specialty at that time, board certification. And when the psychiatric board came out, I was at this place in life where I've taken enough tests, okay? I give tests, I don't take tests. That's what professors do. And I had already established myself in the arena of psychiatry. And a few years ago when that specialty certification came around, I didn't think it was going to add too much to my credentials. I'm also board certified in pharmacology by the same board that certifies physicians. They do Pharm.Ds and M.Ds, the same board. So I thought, well, I've kind of had enough. Now, if I were 25 years old and coming out of pharmacy school and residency and specialty training, I would sit for the psych boards because that's what I do. And so that's how I established my credentials. Today, when people are looking for specialist pharmacists, they're increasingly looking for pharmacists who have board certification. And you can get certified in a number of areas. You probably won't know what that alphabet soup means, but something like CDE, Certified Diabetes Educator, or Certified in Diabetes Management, Board Certified Pharmacotherapy Specialist. That is kind of where those folks fit in to this scheme of broad to narrow and entry level to advanced. But that's the kinds of board certification that is out there, and I think it's something that you want to aim towards with your career. Probably even more interesting, though, to you is, well, what kind of postgraduate experiences am I going to do, if I do any at all? Most people will start with a PGY1 general residency. And that usually, that general residency offers experiences in the hospital and inpatient settings, ambulatory care settings, various other rotations, in medicine, in medication safety, all those kinds of things. But that is sort of the first thing you might think about out of school. After that, you might think about a specialty residency, which is what we call PGY2. And those occur in those areas I've told you about: pediatrics, infectious disease, oncology, psychiatry. There are a number of those. There are also fellowships. And now, you want to differentiate a fellowship from a PGY2 because a fellowship is very focused on research. And so even though I might do a fellowship in psychiatric pharmacy practice, it doesn't mean that I'm going to spend every day taking care of patients with psychiatric issues. I'm probably going to cover the PGY2s or the PGY1s who are rotating through there. I'm going to have some patient care responsibilities, but the biggest part of my job as a fellow is to do some research. And so that's what really a fellowship is all about. And then there are a number of other activities. There are other certificate programs that you can do and continuing education kinds of activities that establish your credentials in those specialty areas. Now, you heard the students mention, I wanted to clarify for you, if I could, just a little bit. About a week and a half ago, Governor Brown signed SB 493. I have to tell you, I was really shocked. Okay, all the other professions around us have tried to do more direct patient care things. If you go to the nursing profession, nurses have tried to, you have nurse practitioners, et cetera, and they've wanted to expand their scope of practice, and sometimes that's a little bit difficult because, frankly, the medicine lobby is really pretty strong, and they tend to hold on to territory pretty well. And so, for instance, you had optometrists who can now prescribe, right? Ophthalmic kinds of things. Your optometrist can prescribe a certain limited formulary of medications. And so pharmacy's been trying to expand its scope of practice for a long time. Well, we were successful this time. And what it does is it allows pharmacists to become providers. Now, that word has real meaning. It doesn't necessarily mean that it's going to allow me to do anything different or more with my patients, because this bill allows us to do things under what's called a collaborative drug therapy management protocol, which is where I work with a physician and I'm working under a protocol that we develop. I see patients, I can prescribe, I can do things under that protocol. SB 493 didn't really change that, but it did say that we could be providers, which means now we can get reimbursed for the kinds of services that we provide. You see, mostly in the past, pharmacists have gotten paid only when they put a product in somebody's hand. And you gave away all the counseling. You got paid for that product, and you got a fill fee for that product. And the fill fee was supposed to cover your counseling and all the other clinical work you do, identifying drug interactions, et cetera. Then along came a thing called medication therapy management, which is a Medicare Part D benefit that many of the elderly have, where pharmacists could bill for that. But for the most part, we've billed for product. Now we have, in California anyway, provider status, which means there's some things that we're going to be able to do clinically, and we'll actually be able to get paid for them. Almost everything I've done in my entire career, which is a little bit over 30 years now, I've done for free. Other than the university pays me a salary, but I don't get paid by patients, and I don't get paid by their insurance companies. That hopefully will change under SB 4093. However, the one thing I really want to stress here is under 493, they have defined what is going to be an advanced practice pharmacist. And that is who is going to be qualified to become the provider. Okay, now, what is it going to take? And I don't know if this has been codified yet by the Board of Pharmacy or not. I just know that that's what the bill talks about. The Board of Pharmacy is going to have to work out how they do this, because this just got signed a week and a half ago. But what I've seen so far is that it's talking about you have to have 2 of these credentials to become an advanced practice pharmacist. One is that you have board certification in areas that are recognized by things like the Board of Pharmacy Specialties, like the one I was telling you about that I have, the board certified pharmacotherapy specialist. So I've got that. The second is completion of a postgraduate residency that requires at least 50% of your activities be involved with direct patient care. So I have that because I did my residency right after pharmacy school. Thirdly, you can have provided services to patients through these collaborative practice agreements, either with a physician or another pharmacist who's been doing collaborative drug therapy management. If you've been doing that for a year, you would meet that. So you have to have 2 of these 3 things in order to become an advanced practice pharmacist. So I think in California anyway, it's becoming much more clear that if you want to become one of these kinds of pharmacists who's doing a lot of direct patient care, managing medication therapy, and all that comes with that, assuring the outcomes, monitoring the laboratory tests, all those kinds of things, you need to be thinking about a postgraduate experience. And what I would think about is doing a residency and then eventually seeking board certification. That, I think, is the quickest route to put you into one of these positions. And I do think that with team-based care, I think that's what the other disciplines are going to start looking for. I know medicine does because we've talked with medicine. They understand board certification because they are board certified. None of us hardly go to any physician who's not board certified, even our primary care people. So that's the end of my talk. What I will do is there's going to be a talk right after me. I'm going to go out to the lobby and spend a couple minutes if you have some questions, and then I'm going to go do this workshop somewhere else. So I will see you in the lobby.